Last time we discussed various phases of endometrium, and now we just shift over to the inflammations of the endometrium. In that, the first is acute endometritis. Acute endometritis is uncommon and limited to bacterial infection, which we see after delivery or miscarriage. Retained products of conception, they also are responsible to be the predisposing cause. The causative organisms are group A, hemolytic streptococci and staphylococci. The inflammatory response is mainly limited to the interstitium and is entirely non-specific. Now, the chronic endometritis is the inflammation of the endometrium which occurs in the various conditions. Number one, patients suffering from chronic pelvic inflammatory diseases, to postpartum or post-abortion patients with retained products of conception, women with intrauterine contraceptive devices. So 3 causes, I repeat once again. Number one, patients suffering from chronic pelvic inflammatory diseases. 2, postpartum and post-abortion patients having retained products of conception, and female with a history of intrauterine contraceptive devices. Tuberculosis, either miliary, spread, or more commonly from drainage of tuberculous salpingitis. That is also a cause. In about 15% of cases, there is no obvious cause, but plasma cells are present along with macrophages and lymphocytes in the stroma. Non-specific chronic endometritis leads to abnormal bleeding, pain, discharge, and infertility. Chlamydia is also involved in endometritis. It can be associated with acute and chronic endometritis. When there is acute endometritis, there are polymorphonuclear leukocytes, but when there is chronic endometritis, one can find inflammatory cellular infiltrate consisting of plasma cells. Antibiotic therapy is indicated for the cure of endometritis. Next, we go to endometriosis and adenomyosis. Endometriosis is the presence of endometrial tissue outside the uterus, whereas adenomyosis is presence of endometrial tissue deeper into the myometrial muscles. Most commonly, both endometrial glands and endometrial stroma are present in endometriosis, but rarely only it consists of endometrial stroma. In case of endometriosis, following sites they are most commonly involved: ovaries, uterine ligament, rectovaginal septum, pelvic peritoneum, large and small bowel, and appendix. Mucosa of the cervix, vagina, and fallopian tubes can also be involved. Endometriosis is also seen in laparotomy scars. It is responsible for infertility, dysmenorrhea, that is painful menstruation, pelvic pain, and this is commonly seen in the 3rd and 4th decade of life. Endometriosis also show the features of invasion to the surrounding organs, and if the muscular wall of the intestine is infiltrated or invaded by the endometrial tissue, intestinal complications like intestinal obstruction or intestinal symptoms can be seen. Now you can well see in the microphotograph, that intestinal tissue is present in the wall of the intestine, and that leads to inflammation. Ultimately, the inflammation goes to the serosal surface of the intestine and leads to invasion. How the endometriosis takes place? There are 2 major theories for the development of endometrium, or for the development of the endometriosis. Number one, the metastatic theory, and according to this theory, endometrial tissue is implanted at an abnormal site, and it is seen that, or it is postulated that retrograde menstruation through the fallopian tubes occur regularly even in normal women and could mediate the spread of endometrial tissue to the peritoneal cavity. So that is that if even in the normal female, one can find or one can see the menstruation is retrograde, and through that fallopian tubes, the endometrial tissue can spread to the peritoneal cavity. Endometriosis is also found in the cervical mucosa, particularly following surgical procedures, and that is even the laparotomy scars after caesarean section. That supports the implantation theory. Endometrial tissue or endometriosis can be seen at distant sites, and here the spread is through the blood or lymphatic, and we use the word metastasis. The other theory is metaplastic theory. Endometrium could directly arise coelomic epithelium from, that is the mesothelium of the pelvis or abdomen, from which the Mullerian duct and ultimately endometrium itself originate during embryonic development. So this means that there is metaplastic theory, that the conversion of the coelomic epithelium, which is found in the embryonic development. There are many other factors which support the spread of the endometriosis, or which support the development of endometriosis. Number one, there are genetic factors, hormonal factors, immune factors, and there is profound activation of the inflammatory cascade of many chemical mediators like interleukin 1 beta, tumor necrosis factor, and interleukin 6. Beneficial effects of COX-2 inhibitors on pelvic pain, an important clinical feature of this disorder. It is seen that there is estrogen production by the endometriotic stromal cells, which is markedly increased, or we can say which is markedly upregulated due to, in part, to high levels of the key steroidogenic enzyme, and that is aromatase, that is highly responsible for the upregulation. This enzyme is absent in the normal endometrial stroma. Estrogen enhances the persistence of endometrial tissue, with the result that inhibitors of aromatase are beneficial in the treatment of the endometriosis. Endometriotic tissue is resistant to the anti-estrogenic effect of progesterone, which suggests that progesterone resistance also play a role in endometriosis. Foci of endometriosis, they respond to both intrinsic and extrinsic hormonal stimulation, leading to the periodic bleeding. Now, once the bleeding takes place, this produces small nodules which are red, blue to yellow, brown in color, and they are just beneath the mucosal or serosal surfaces. When the hemorrhage is organized, or when the hemorrhage becomes old, there is extensive fibrosis, and with the result, adhesions developed between tubes, ovaries, and other structures, obliterating the pouch of Douglas. The ovaries are the most common site of endometriosis, and they become markedly distorted. Cyst-like structures are present, which are 3 to 5 centimeter in diameter and filled with brownish material, which are previous hemorrhages, and they are called as chocolate cyst or endometriomas. Aggressive form of endometriosis can infiltrate tissue and cause fibrosis, and ultimately there is adhesion formation. If you see under microscope the histology of these endometrial cysts, they are composed of both endometrial glands and stroma, with or without presence of homocysteine. In very rare cases, only stroma is identified. Clinical features. It depends upon the site which is involved. There can be dysmenorrhea, pain during intercourse, pelvic pain due to intrapelvic bleeding, and periuterine adhesions. If rectum is involved, pain occurs during defecation. Dysuria occurs when there is involvement of the urinary bladder. Intestinal disturbance appears when small intestine is affected. Menstrual irregularities are common and infertility is seen in 30 to 40% of females. Malignancies can develop in this setting, suggesting that endometriosis contains at-risk epithelium. Now, I told you that adenomyosis is the presence of endometrial tissue within the uterine wall, and if the endometrial tissue is contained in the leiomyoma, we call it as adenomyoma. When endometrial tissue is present within the wall of the uterus, there will be irregular and heavy menses, colicky pain during menses, pain during intercourse, and pelvic pain, particularly during the premenstrual period. Now you can well appreciate this photograph which shows adenomyosis.